When do patients typically come to you and get care anyway, Ed? I mean, what triggers somebody to say, I've been living with this, it's been itching, I've had all this, but today I'm coming for medical care?
Really can come from anywhere. Somebody might be ignoring it or self-treating, but they're seeing an allergy specialist for something else. They're seeing a pulmonologist for their asthma, and those physicians are well aware that atopic dermatitis goes along with those other conditions that they are treating. So we're going to see that these patients come from a number of different places, including going to see their internist and just saying, I give up. You know, I can't self-medicate enough to make this work. I'm taking antihistamines over the counter, I'm using various creams, and it's not working. So ultimately, these patients will see the dermatologist if they fall into the moderate to severe category. And they need to if we're going to see management with new medications, because all of those other specialists and primary care physicians are not going to be familiar with the new medications.
Well, at least not at first, right? I mean,
Right.
it would
It may
percolate
take a
out.
while.
Right.
Mhm.
But at some point, I guess what I'm really asking about is, yes, little kids, parents are going to bring them in. I mean, I thought that as a doctor when I had little kids, you know, I'd be immune to this, but no, my kid's got a hangnail and they're going to the pediatrician.
Yep.
I'm sorry, it's true. That being said, a grown-up who's been living with this, is there some trigger where the grown-up says, that's it, I've had enough? What typically brings them to a dermatologist?
There are those triggers, and Jonathan sees this all the time, you know, is that they finally go, I just can't take it that I can't sleep. Or their spouse says, I'm going to push you out of bed because I can't sleep,
Absolutely.
right? So those sorts of things happen. Sometimes they're just fed up, or sometimes there is a particular instance. I really want to learn to scuba dive, but I can't stand being outside in a bathing suit because people see this, right? Okay. So there's all sorts of things that bring people to the doctor, but a lot of times it's because they just can't stand those symptoms, and especially the pruritus.
I mean, I can imagine it when my kids get mosquito bites and whatever, they're scratching all night.
Absolutely.
It's terrible. And imagine this, if it doesn't go away, it's a chronic condition and stays with you forever. And the medications aren't working. So it comes back to you, Jeff, because you're talking about the pipeline and you're talking about the expense. But we're talking about direct and indirect costs of this disease. I mean, not just money, but the social cost, the psychological cost, the psychosocial cost. This is a big deal. And what about comorbid conditions and all of this affecting the cost?
Yeah, again, this is not a focus right now for payers. It's off the radar screen because, again, of the generic and over-the-counter versions. But it speaks to the unmet need and around education on what this is. And with that is, what do those outcomes mean? Because payers generally don't focus on indirect costs and quality of life in their analyses when it comes to formulary management. So right now, most of the cost of this disease is indirect or really low direct, but that is going to change. And so that's the need right now is what are those direct costs? And we don't want to be told that this helps sleep. We have inexpensive sleeper medications that we can use, right? So it really comes down to how does this treat the disease? And if we get those extra benefits, that's fantastic. And hopefully those are the outcomes that we're getting with the drugs. Right. But we cannot prioritize that way.
But don't we think that there'll be times and patients will seek additional treatment when they have flares, right? So this is a disease that the patient's up and down. And most likely it's going to be the adults who are going to come more so to seek that treatment. And it's not 30 million, it's probably 2/3 of those are mild to moderate, and most could be controlled for the most part by over-the-counter or topical steroids. It's going to be a small subset of those patients who really have issues.
It's never the full amount.
Right.
It's never the case. And there's going to be a lot of analogies here with psoriasis. So, a decade ago when we had the biologics that were launched for psoriasis, there was major concern. Those were tightly managed. We were asking about body surface areas, and we were doing all kinds of things. And now I think the approach is generally more open because we're comfortable a little bit more with who that patient is. I think we're going to see a similar approach here. But my point is, when we're talking about a value proposition of these new drugs, it cannot be around some of these quality of life. It has to be more around functionality and direct, because that's what we that's what
All
we're
right,
going
well,
to
forgive me, go ahead.
Well, but some things that are sometimes lumped into these quality of life questionnaires and things like that actually are really about patient symptoms. And so that's really part of the clinical story here. So, when payers hear quality of life, sometimes what they're thinking about is some sort of convenience factor or something that fits into some social mold that's not quite what they normally deal with. But patients have symptoms, patients who can't sleep. These are important symptoms, and you can put that more into a clinical context and don't lump them in with a bunch of other things.
I agree.
right?
If they're disease specific and they're linked to outcomes, then we'll look at those.
But
Right.
I mean, let me be a devil's advocate here, and a little bit mean. Because I heard you say, well, if it's about sleep, we'll cover a sleeping pill, or some sleep med. But it's not about sleep, is it? It's about the fact that you're itching. And sleep is only
Absolutely.
the byproduct
So the
of
message
that.
is sleep and all these other things improve because we're affecting the disease state and the inflammation and the itching. So again, it's the value prop. So I don't want to discount this, but again, we're not using these medications to treat sleep. We're using them to treat atopic dermatitis, which helps these other
Okay,
things.
that's fair, I guess. I mean, we're all on board with that. You're not going to break it down into various slices of symptoms and treat one individually. You're going to say that the whole picture here affects sleep. So if we treat A, we'll get that as a side benefit. Is that worth it to the insurance companies?
You have to be talking about direct
Okay.
and objective.
Okay.
And if we can accomplish that and we can show an improvement in the disease state, then these things are absolutely.
Then they all fall out.
But if not, then no.
And do you think that it would be better to look at the subsets of those patients? These are the mild to moderate and then moderate to severe. And for a patient who's moderate to severe, who has incurred all of these additional costs to the health plan related to sleep aids and skin issues.
I don't think payers will have as big of an issue in that population. That completely makes sense. So, but that speaks to the difficulty, I think, in the payer environment of who's mild, who's moderate, who's
Okay.
severe. We don't have good tools for that, and we're never going to get that in claims data. It's like asthma. I mean, you have 6 stages of asthma. We can't determine. That's a clinician's perspective. So we really need, again, objective measures that we all agree on, and how we determine who is a candidate for these types of drugs. When do you start? When do you stop? What are the algorithms? It really is about the appropriate patient.